All right, I believe we are live. Good afternoon, everyone. This is United Medical ACO. My name is Kemal Erkan. Today is January 21st, Friday. Delaware Health and Community Updates is our goal for today. Again, our weekly event. I have Sean Donegan, who is helping for this event to happen. And he does put a lot of time with me for this. Thank you, Sean, joining me. How are you doing?
Of course, not a problem. I'm doing well. How about yourself today?
Very good. So we are going to go ahead and start. We have some updates from the COVID-related issues, and we have some healthcare-related updates. And later on, Katie is going to join us for revenue cycle management updates. So we'll go from there. First and most, let's start with our agenda. All right, so.
Yeah, so we have our cartoons again this week on the US News. We have a couple of features. We have two. Starting on the left, we have Dr. Fauci. Obviously, for those who know the Looney Tunes cartoon, doing a spin-off on that with the Looney Times. And obviously the slogan with Looney Tunes was, that's all folks, meaning obviously at the end of the episode, a conclusion to the event. But here it's Looney Times because it says that's not all folks. So obviously Dr. Fauci here, the new variants, kind of taking the stab at it. It's kind of a never-ending thing with the new variants keep emerging. So, we're hoping that we are progressing to a finish. Obviously, the sooner the better. But that's kind of where that stab is going. That it just seems to be a never-ending if there's a new one.
So, Sean, do you have any idea about Dr. Fauci's age?
I know he's older than me.
Everyone is older than you.
Right.
23. So he's over 80.
Okay. Wow.
All right. So what's happening with the COVID numbers?
Yeah. So here, as we know, we do have that spike from all the way back almost New Year's time into the beginning, first 2 weeks of January, and it seems to be continuing up until this kind of last week. We kind of see that spike starting to come down just a little bit in the graph. So as we highlighted there, the number that we're only down to 750,000 cases as it was 770. So kind of reached the peak and are now on our way back down, at least in the United States specifically, with those numbers right there on the chart. And then again, another graph. This one may be a little bit easier to visualize that spike coming down as the red trend line is highlighted. But you see there's that 1 day surge. Again, it was around New Year's. I know with the holidays closed, a lot of the counting was suspended for a day or two. So kind of all piled up. But overall cases look like they're on the downtrend now that we kind of reached that record number, now heading down. And then also just to keep in the back of our minds that, it's not necessarily the number of cases, but kind of the severity associated with them. So I know a lot of people who may be getting the Omicron variant may just be a 2-3 day cold, testing positive, but overall the severity is not anything near that we saw with the Delta variant. And then, just the United States vaccinations here, highlight at the top that we had administered at least 530 million doses. That's an increase of 8 million from last week. So pretty significant number right there, enough to cover about 80% of our population. This may be attributed to the pediatric population a little while ago they were able to receive the vaccine. And I know maybe some parents weren't super urgent on getting them done, thinking, put it off, not super urgent. But now that we did see those record number spikes, that may have helped influence some parents maybe getting their children vaccinated sooner. So that may be why we saw a significant increase, up 8 million in the last week for the United States.
So last night in our providers meeting, we had these numbers. Let me actually just see if I can bring it up. So I did send you a link earlier. So just to break down of the hospitalization and who's actually really vaccinated and who's not, and what booster really does. And I do want to bring this up so that we can share. So the booster actually is the key. So if people don't have their boosters, so this is the main thing that's going to protect you against the Omicron variant. So now this is something that I was actually just looking for this morning when we were giving the overall numbers. We don't want to actually assume everyone is not vaccinated, but getting boosted was 90% effective versus getting 2 shots is like 57%. So this is what I was looking for last night. So that actually is a pretty powerful statistics. So I think people should really know this. So 90 versus 57. Now, even at 90%, that means 10% chance of not, it may not work. So, but 90% is a really good number to have. So when we are fighting against these statistics. So we want to increase those numbers as much as possible, our chances of not getting it. So that's kind of like what we are trying to do. So what's the overall numbers that we have?
Yep. So again, the United States, we're almost at 210 million people being fully vaccinated. And then again, with that booster that you're just touching on there, we have almost 82 million people having received a booster dose. So like you said, obviously getting the booster is definitely going to help your chances of not, getting the COVID virus. And obviously anybody would agree that you'd rather have 90% chance of not getting it as opposed to almost a flip of a coin at, 57. So obviously it's super significant. And, as we see, those numbers are still steadily rising. So it's definitely good to see. And then also, kind of just the antibodies with having such a large number of cases with the Omicron, even those who maybe are not necessarily getting vaccinated kind of have, at least if they did test positive for COVID, they at least have something in their body helping fight against it. So overall, I'm pretty optimistic, I'd say, on the future on these COVID numbers and the cases. And then again, just the severity that we're seeing. I just think it will not be as severe as we proceed forward. Yep. And then here we have our numbers for Delaware. So as you see here, fully vaccinated over 630,000. So it's a good number to see. Obviously, we're hoping it goes higher. See total vaccines administered over 1.5 million. So pretty good for Delaware here. And then obviously it's broken down by the vaccine status of their age. So fully vaccinated, 65 plus community is still leading those groups at 93%.
So the main issue these days is the mask that we are wearing, what type of mask we are wearing, and how we are utilizing it, where we are utilizing it. Right now, the indoor is mandated, but I think we cannot emphasize the mask utilization enough. So everyone should be using a good quality mask and not to make that lightly, because that is the main protection these days. So from our United Medical Clinic side, we do have an update. Two of our practices right now, they are going to be, they started being under one umbrella, Medical Associates of Bayer and Dr. Irene Zito. Now they are going to be with United Medical Clinic. We welcome them. They started as of January 1. Right now we are about, I believe, 17 or 18 providers total. So we are going to ask Katie Needles, one of our client managers, to join us, and we're going to discuss revenue cycle overview from United Medical side. And Katie, how are you doing?
I'm good. How are you?
Good. You see, it's always better with the flag. So Katie is gonna, we have done this in a couple different sessions, but as we actually, we have a couple different purposes with these events. We try to reach out to our patients. We try to reach out to our employees, and also we try to reach out to the public and some potential clients. So it's a good way to communicate with a lot of different people from the same channel. So this is one of those where every other week we are rotating between the revenue cycle management and the clinical issues. So today is the revenue cycle management week. So Katie, you are on.
Okay, thanks. Okay. Get started whenever we get this first slide here. So as Kemal said, my name is Katie Needles. I am a client manager here at United Medical, and I'm in the accounts receivable department. So what we really work on my side is revenue cycle management. So we do have many clients that we do the medical billing for, but more than that, we want to make sure that the revenue cycle, the entire process of seeing the patients, collecting any revenue, that it's comprehensive. The way that we're able to do that is by partnering with Cerner and Cerner resources. So we use PowerChart as our EMR. We use two practice management systems of SPM and CPM. So that's where they're actually going to enter the visits. And then that all interacts with QuickBase. It's a constant feedback system. So PowerChart can talk to SPM, can talk to QuickBase. Everything is able to communicate in a cycle. This is a very tiny screen, but basically this is just the summary of our workflow. So if you take a look at the top up there, we start with the doctor's office and it's going to work its way through. Whenever a charge is entered, there's many opportunities where something could go wrong. And part of my team, the goal is that we want to reduce those errors and get that claim processed as quickly as possible. The charge is going to start with the doctor's office, and from there, it's going to go to the United Medical Systems verification. At that point, it'll go through a scrubbing process. Is there anything wrong with the name? Is there anything wrong with the zip code? Any sort of a manual error that we're able to fix. After that, it's going to go through our clearinghouse, go through electronically. That's where the claims are going to be sent to the insurance. No more of all paper claims. This is all electronic, which allows us to get payments faster. After we go through that, the insurance will accept the claims. And after that, they'll come back as ERAs, which are electronic remittance advices, or sometimes on paper EOBs. This is where the insurance is going to give us a determination of what happened with that claim. Was it paid? Was it denied? At that point, my team will take over and either the payment posting department will post, or my team will work on correcting that denial. Denials can come from a multitude of reasons, whether the patient wasn't eligible. Sometimes we do have to fight with the insurance. Sometimes they're legitimate things. And unfortunately, sometimes we do have to fight a little bit to get things paid. But that's what my team works on from those EOBs. We also utilize a reimbursement manager. That's the way that we organize our claims in order to see what needs to be worked. It's a queue of sorts that we can work through those denials. All of that goes to the AR team. And at that point, we're going to chunk it up a couple different ways. Does it need to go to a secondary insurance? Do we need to bill the patient for a copay, co-insurance, deductible, or is that the end of it? But it's a whole cycle, therefore the revenue cycle.
So if they are rejected at this point, then?
Correct. So if we do have a rejection, it'll go back to the AR team and then it goes back up and goes back through the process.
Yep. So, all right. So I will clear this.
So this is our clearinghouse and our denial management. As I mentioned, part of the big thing that we do is work on rejections and denials. So on that top where it's highlighted in green, it says manage payments and manage reimbursements. We're able to work the denied claims from there. Right underneath of that, where there's that orange highlighting, we can work the rejected claims. Essentially, TriZetto is almost like a toll bridge of sorts where claims have to be passed through the scrubber and then they'll come back from the insurance. All right, so this is going to talk about our Decode, our denial code correction system, and this is how we ensure precise reporting. So often insurances will come back with a really vague denial or some sort of a communication that doesn't always make sense, or they'll have a code that says PR288. So rather than presenting that to the providers, which doesn't make a lot of sense, we have a coding system called denial codes. where we look at the reason why the claim was denied. Was the insurance wrong? Was there no referral? Was there no authorization? That left snippet there, that left picture is a picture of SPM, where we did put in a decode DCVD, where we identified that COVID shots actually have to go to Medicare if the patient has a managed Medicare. What we do with this system, as you can see on the right, is we have a lot of different codes that we utilize this to report back to the client on a monthly basis of, we had 30 eligibility issues this month, or 20 patients had Medicare and we need to send the vaccines there. It's a really good feedback mechanism so that the office can identify issues that they're able to resolve on their end, which in turn will reduce denials and increase revenue. Kind of already touched on this a little bit, but SPM reporting. So we have different mechanisms for daily, monthly, and scheduling that are all going to work between SPM and through QuickBase. Some of the daily reporting will be that we use SPM to track our daily codes. So as I mentioned, those denial codes before, it also doubles as a way for us to see what our employees are working on. How many denials are we able to work through in a given day? All of this we're able to work with QuickBase, and it makes it a very easy format for us to monitor the decodes, the production, the denial rates. We also send out monthly reports to all of our clients where we compile all of those decodes and present it to them. Kemal, you can speak on the scheduling portion if you want, but I do know we also use QuickBase to assist in that as well, mostly for CRIAS and other clients like that.
For the on the SPM side, with the practice management portion is done through the scheduling. So it's not just the billing part, but it's also the scheduling and registration. They're all done through the PM system. So SPM is not just for the billing. That's what we have. Why we have it there. So because like many. Actually, for a second. So many practices, many revenue cycle management companies, they were not actually sharing, they were not using the same real-time systems with the billing companies, with the revenue cycle companies. So what's being used in the office versus what's used in the practices with the vendors, they were different. So because we have it all integrated with the offices, so then we don't have that problem. So we do want to emphasize that they can actually do their scheduling through the system. That's the scheduling.
In the QuickBase reporting, so we do have many different specialties that we do the billing for. Other than behavioral health and dental, I think we've done all of the different specialties that are out there. So we'll have urology, podiatry, pulmonology, we have cardiovascular, but then we have regular PCPs as well. So QuickBase allows us to separate those denials out. We're not going to compare the American Surgery Center to Brandywine Podiatry to United Medical Clinic. They're all going to have very unique issues with unique specialties. On a monthly basis, we compile those reports, as I said, and we'll look at 3-month averages to see what are the trends. We're able to separate that out by the different specialties. Each one, like I said, is going to require different setups. So the American Surgery Center is going to be very different than Brandywine Podiatry. That could maybe utilize DME or durable medical equipment for a patient's foot. They need actual physical items here. So it's really helpful for us to be able to differentiate between the types of specialties. This allows us to just really differentiate between the practices. Good. Thank you. So for our collections process, we do implement efficient processes through SPM that identifies patients with overdue balances. Generally, we do have statements that are sent out to the patients, but after that, our collection teams reviews the accounts to assure that sufficient statements have been sent to patients prior to including them on the collections list. Our practices do have the opportunity to go through that list and double check everything, make sure that it's all up to date according to their standards before they are transferred to a third-party collections agency. This is going to result in a cleaner system. We don't want balances to be sitting out for years and years with no sort of collection. That's not really ideal for the revenue process. All right, on to client satisfaction. So our team worked really hard here, and we're always looking for opportunities to improve, but we do send out client satisfaction surveys either on a monthly or at a quarterly basis. So as of last year, our billing department has a 97.2 positive client satisfaction rating when asked if they were satisfied with the services provided by United Medical. We have a couple of nice quotes here pulled from a couple different teams. I do have a couple of mine on there, which is always encouraging to see that the providers and the office managers, that they really do appreciate the work that we're putting in here.
So I think right now we are in the last 3-4 quarters, it is 100%.
Yep, I think that's on the next slide as well. For if they're satisfied with the billing itself, it was actually at 100% with the client managers, which again is pretty fantastic and makes us feel really happy to do our jobs when we have 100% satisfaction rating. Payment posting managers have earned a 95.9% approval. And it's not that they're not at 100%, but often there's a lot more that goes into payment posting. And we're always taking the feedback from our clients to figure out what posting mechanisms we can improve on.
All right, I believe.
All right, do we have time for this one as well? Come on. Okay, so just speaking of our billing, so the point of the revenue cycle management is anybody can just do billing or anybody can post payments, but the idea of revenue cycle management is that we want to use a comprehensive system, systems that are going to talk with each other, that are going to interact and ultimately to increase revenue. So whenever we take over on a client, on average, we see a revenue increase between 5 and 15% after that takeover. We have seen clients that have gone up from that between 20 and 35% over a period of 1 to 2 years. A lot of this is because we're able to streamline that process and make sure we're looking holistically rather than chunking items up. For a client example, we had a new podiatry client that joined United Medical in April of 2018, and the client was already using the same platform. So we didn't take them from another software system. They were still using SPM. United Medical was able to increase the revenue by 32% at the end of 2019. That just really goes to show that you can be using the software system, but the unique revenue cycle approach is really beneficial for the practice. So as that last bullet, we are really focused on working together.
So I think just this past week, and this was one of your clients, what I realized, it's been almost 22 years that I've been doing this. And as I think that everything is more straightforward and more streamlined, insurance companies are more creative. So, and although the regulations are very heavy, insurance companies are finding their way to do stuff in a way that if they are able to get away or if they're not being caught, then they can do stuff. And for example, we won't mention the name, but one of the Medicaid managed care companies in Delaware is doing a prepay visit, right? Was it the prepay payment?
Essentially, they're doing audits prior to issuing payment.
It's almost like a penalty for the practice. So basically what it is that they don't pay until they receive the claim. They ask for medical records, and then they review the medical records. This is a very lengthy process. It can be, and they don't have resources. That's the other thing. They don't have the right place to send the medical records. I don't know if it's Delaware or not. And they also did not communicate this in the proper format. So, and it's against their contract with us and with the state. And this happens. So, and you would think that this happens in some third world country, but it happens in the United States. So, and that's why when we are actually doing everything that we can, and we do, this still happens in today's insurance revenue cycle management world. So that's why we have to do what we have to do at the best level that we are doing. So Katie was part of that investigation that we did with that client. And when that's needed, you need all the expertise all together. And it's not just with one person, but our entire team was there. And that's what's needed from the revenue cycle management. And Katie is one of the best managers that we have. Well, thank you for being with us, and thank you for the presentation. All right, so we are gonna go to a little bit more fun, maybe stuff. So, Sean, are you back?
I am back.
All right.
Ready for the fun. All right. There we go.
So the loser of the week. I never liked him as a tennis player, so I'm a tennis player. So, but he is a miserable person, and but why is he the loser of the week? Not because he beat this person up.
No, yeah, that was at the U.S. Open when he I don't know if it was out of frustration, he didn't get a call, but yeah, tennis ball, line judge's neck. Djokovic got him tossed from the tournament.
He hit the line person, but that's not the reason for him to be the loser of the week. It's because he was outed from Australia, and now he's not able to go to French Open. He won't go to most likely the US Open, and he's not gonna most likely go to UK. So why do we have to discuss this in the session?
Right.
Because it's all happening because he's not getting vaccinated.
Yeah, he is not getting the vaccine, not getting vaccinated, which obviously it goes against the protocols of these particular tournaments that all the other, assuming participants, obviously officials, fans, anyone who might be attending are all obviously following accordingly. And
he's back home now.
Yeah, I think he's from Serbia, right?
Yeah. He's having coffee with his prime minister. Okay, more serious stuff. What's happening here, Sean?
Yeah, so obviously COVID, we're trying to see, is it actually winding down, with these new variants, how if it's, spreading more quickly and more people are getting it, we have antibodies, we have more vaccines, more vaccination going on. Is it actually going to dwindle? And the WHO kind of taking again another stab at the vaccine distribution. They're kind of saying that we want to get as many people vaccinated in a shorter period of time. That way the virus doesn't have a chance to again mutate and have new strands kind of take off. So you want to kind of get it all at once in a more efficient manner. And by doing that, it's saying that we kind of have to direct efforts towards some of the poor, maybe third world countries that aren't necessarily able to afford or administer vaccines at the rate of which more wealthier countries, more affluent ones are able to do.
So we have the breakdown of those countries where the vaccination ratio is, right? So it shows.
Yeah. So this little graphic that I kind of put together here on the left side, we have some of the poorer countries. So just numbers that I threw in there for our data to be compared is kind of the total population of these countries, how many COVID cases they saw, and then of those cases, how many were resulting in death. And if you look at the highlighted that you're actually circling there in the yellow, that is also going to note the number, the percentage of the population that has been vaccinated. So if you look at the poorer countries, their percentage of cases that resulted in death are a little bit higher. So you see Somalia had over 5% of the cases resulting in death. Liberia was at 4%. And if you see that they have really low percentages in vaccination, as you just circled there in those yellow highlighted spots. Whereas on the right-hand side, we have our wealthier countries. So you see the US, Japan, Luxembourg. And if you look at their percentage, so even there at the bottom, Luxembourg, having 124,000 cases, of those only less than 1,000 resulted in death, so it's less than 1%. But then if you look right below it, percentage of their population vaccinated is almost 95%. So it's obviously not a coincidence. There's some type of direct correlation here with a vaccine and the death rate that you're seeing with people who are contracting the COVID virus. And like I said, not a coincidence. There's definitely a little bit of science behind the numbers there.
What we know from this is that when you have the money, you get the vaccine. When you don't have money, you don't get the vaccine. Is that?
Yeah, that's kind of the gist of it, and that's kind of what the WHO is kind of trying to say. If we could, help out or kind of be a little bit more efficient with the distribution to those countries who maybe can't afford it or just having difficulties administering.
Things may change soon because the inflation is everywhere, and including in US, right?
Yep.
And percent is not even the right number, but that's the official number for now.
Yeah, so I mean, if you look at particular goods and services, I know even across the sectors, I think the energy sector was the highest of inflation that was impacted. But if you look at other things like gasoline prices, it's kind of odd. If you look at the prices of used cars, they actually beat the S&P 500 index on return just because of the inflation. So obviously 7% was kind of the average that they were doing. But if you look at specific goods and certain sectors, it's actually way above 7%. So if you see here, it's kind of breaking down the U.S. in different geographic areas. So how much it was to fill a tank and the percent change from the year 2020 to 21. And across the board, obviously, it's an increase. If you look at all those trend lines going up and to the right, especially even like look at California, I think they always have the most expensive gas, obviously increasing across the nation.
Well, this is actually one of the things that we've been talking about, right? So that is, and I keep saying the same thing, and then I'm never happy when I'm right with these types of stuff. So these are videos I'm going to try to play to see how it's going to show. These are from the local supermarkets. I'm not using anyone else's videos. These are from, I think it's from Acme. So this is one, and then this is another one. I had actually one picture from the week before, and so this is a little bit closer pictures. So with the inflation and everything else, but then there's also the lack of goods in these stores because people are not working with a lot of the restrictions that we have. So what's expecting us is that I think there will be some type of crisis going to happen, economic crisis. I don't think people are understanding this.
Yeah, because I mean, another thing too, I know right now, actually truck drivers, there's kind of a shortage of truck drivers nationally, and obviously in high demand. The wages actually to be a truck driver right now are actually really high compared to what they normally are, just because of that supply and demand. And it's kind of a sign that may help us, predict what's coming. Like you're saying, a little bit of crisis if, there's just not the effort and supply, even in the workforce, like you're saying, that you kind of need to keep up with what we're used to having.
So maybe next week we can use this graph here, but what it shows is the purchase power of the dollar.
Yep, and it's not a good graph to be looking at. So you're saving money, saving money in cash.
People understand this. They think that we are talking about something political here, but it's not. It's just like what it is. Like sometimes I'm not out there shopping a lot, but I know what it costs like 10 years ago versus what it costs today. So then when it's expensive, it's expensive. When it's more today, it's more. So you feel it. Now, when, sometimes in the American culture, we have this issue of when there's a little storm, then the stores are empty.
Mm-hmm.
Kind of that. But now what we see is with the COVID, it's almost like a permanent lack of goods there. So that's happening. So it's out there. Anyhow, so one of the other things that we are going to discuss today, which we did introduce the NeuraLink, and we find this interesting, and hopefully everyone else does. We wanted to kind of deep dive into the NeuraLink a little bit more. Personally, I want to understand a little bit better, and luckily Sean agreed that he wants to understand this a little bit more, so we are doing a little bit more reading and understanding. So this has a future in healthcare for sure. So how it works, understanding the brain, interfacing with the brain, and engineering with the brain, these are directly from their website. This is the future of healthcare. whether we like it or not, it's going to be there. Now, I own a surgery center. When I was going through this, my first reaction, one of my reactions, not the first reaction, is, well, maybe we can do this at the surgery center, like in the next couple of years. So I borrowed this image from one of the videos, and basically a small object is being implanted on the scalp here, and it does actually have a lot of, it promises a lot. So
Yeah.
now it actually, now from the time that we discussed this to the time now, there are new stuff coming up. So now they are talking about another interface with the Metaverse that we are going to discuss. So Sean, talk to us about the simulation.
Yeah, so right here, obviously, like Kemal said, we are expanding on the NeuraLink, with the different stimulation and how it's going to interact with the neurons in the brain. We talked a little bit, I think it might have been like 2 or 3 weeks ago when we first introduced it, how we thought that we saw the monkey actually being able to move the computer with its brain just by the chip in the brain reading the neural network, the synapse, between the synapses and the neuron and the feed.
Mhm.
But now we're also seeing that it may be used for, almost a memory sort of storage. If you think of almost like a hard drive backup type approach, where not necessarily just on, say, that particular instance of, maybe solving paralysis, more the physical side of healthcare, but also we have that mental where, like you're saying, the memory storage, more of a psychology, cognitive approach, obviously cognitive with the brain, but as opposed to not just a physical, being able to give access to maybe limbs that were previously paralyzed, but also like a memory. So like you're saying, I think it was a few weeks ago, you mentioned that not necessarily always to be used in patients who may have a disability or a health concern, but also in people who are considered, to be the most part overall healthy, that would be able to be implemented into them as well.
Yeah, and the other thing is, we know that there are certain conditions these days. It comes with the aging, and the Alzheimer is one of them. Now, we had our providers meeting last night, and one of the issues that came up was the medication is used for Alzheimer, which is about $60,000 a year today. When I was doing the research on the potential cost of the NeuraLink, they talk about maybe like $5,000 per implementation, so per implant. Well, today someone is willing to pay $60,000 a year for medication that may or may not work. And then we actually, let me actually just go to did we have the medication on the later part?
It should be, I know we had it in one of the slides there. But yeah, looking at the medication costs there, obviously, when you compare the two,
so if you're going to spend that kind of money,
yeah.
then you are kind of, it's actually a little bit in the, let's just bring it up. So this is real. So $56,000 a year. So if someone lives 2, 3, 4 years with the Alzheimer's disease, so they can actually cost $250,000 to $300,000 just for one medication. But something like this, something like NeuraLink, can actually be the answer for many of these. Now, of course, it needs to be regulated. That's different. Now, we are going to actually study this more and more, and we are going to bring this up, and we are going to know more about it. But one of the things that we started, we are asking our people whether or not they want to have this. Now, before I go to that, Sean, tell me about this slide.
Yeah, so here, if you see Person of the Year on the Time magazine cover, Elon Musk, and I think in the news, sometimes people maybe only see a little portion of an event or a person or something and kind of just associate that as a one-to-one. But, I don't think if you zoom out, I don't know if a lot of people realize how many other different companies and kind of innovative technologies he's actually been involved with across the board. So, you're looking at some of our popular companies here that he's either the CEO of or has actually helped start. So you're looking at, PayPal, the SpaceX. He's looking to, obviously, that's technology and innovative ideas there, obviously with our outer space and, the rockets, and trying to just obviously advance in that field too. But obviously Tesla with our auto driving cars now that they have that feature in some of the Teslas. So a lot of the artificial intelligence across his companies is kind of a common theme there. And obviously NeuraLink clearly relying on the artificial intelligence there.
Your point is that if he has done all these, so this is going to work at some point.
Yeah, I would say not a coincidence. He's obviously had numerous successful companies there. So obviously he has enough resources. And I know in our previous video, a lot of people were saying, oh, what's, the risk and how the safety concerns and what percentages they have to meet. And he was saying how even Tesla, as his other company, they exceed what the FDA requires as the minimum safety. So especially with NeuraLink, he wants to be safer than what's even the minimum required, which obviously is a optimistic and a good sign as someone who's behind this.
One really important part with NeuraLink is one is you can actually move objects with the thoughts in the brain.
Yep.
Like you can actually, without actually touching them.
Correct. Yeah. So it's the chip in there will actually read the neural signals that your brain is sending, and it actually interprets them, and then would result in the physical.
And the other thing is that the actual interface of something is being uploaded into your brain.
Yeah. So there's obviously the computer signals.
Right. So something is being downloaded. So something that you don't know and it's being downloaded. So those are like. If you don't know what it is, it's scary. But once you know what the future is and what we have done in the last 20, 30 years, so and look at the next 30 years, this is going to happen. So it just needs to be regulated properly and needs to be controlled well. But it has a lot of promises, good promises.
A lot of potential for sure. And, another thing too with those computers is that as people may know, computer systems learn themselves. So I don't want to necessarily use the verse trial and error, because obviously we're talking about eventually getting to humans, but with different examples to say the computer will learn itself and begin to almost reprogram itself to become more efficient, and obviously minimize those percent chances of error in the future to become even more safe, more efficient in its operating.
Definitely. So, but here's with the limited number so far that we have, here's what people answered. 12% says yes, they would get the implants, and 47% said no, and then 41% said maybe. So I will keep this poll open, and then we'll periodically give an update. But actually, right now it's 53%. So it's like the Republicans and Democrats.
There you go, sitting on the fence right there.
So. I didn't say which one is which though, right? So, but it's close. That means people are open. So that's what we have for today. We'll be back next week with different things, but NeuraLink is going to be one of our focuses for this year. And we just want to learn more and know more about it, learn more about it. And hopefully we can share those with you. Who knows, maybe one of those days Elon Musk will join our session. So it's all possible, right? So we'll be back in 10 minutes with the Bariatric Friday with Dr. Erkan. Until then, stay safe. And if we don't see you at the next session, please use your mask and have a nice